what is the question you need to ask in history? My voice clear?
Yeah, it is clear to me.
Okay.
Yeah, I don't.
Interact with me, please. On set, very good. Start and progression, very good. Duration, drug, very good. Fever, rash. Okay. Infection, very good. Preceded by UTI, viral infection, trauma, comorbidity, family history, history of trauma. Okay. What are the signs to be picked up from the examination? Signs pick up from examination. Wide base gait, very good. It is a common presentation. Nystagmus, yes. Tremor, intention tremor. Telangiectasia, okay. Coordination from Berg, very good. Dysdiadochokinesia, dysarthria, positive from Berg, speech, okay. Very good. What investigation we need for patient with ataxia? We talk about acute ataxia. MRI, CT, head, okay. CSF, CRB, CSF analysis, toxin, direct toxicology, very good. Okay. How to manage a patient with acute ataxia? How to manage the patient with acute ataxia? ABC, very good. Safe, safe. Admission according to the cost. طيب تمام. طيب. Okay. Dr. Mutsir.
Dr. Marwa, is there any problem
Slide.
in your
slide.
الصوت اختفى. ايوه.
لا الصوت. ايوه.
اوكي.
الشير.
اوكي.
طيب. Ataxia disturbance in smooth accurate movement of coordination. Ataxia result from the cerebellar or posterior column tract of spinal cord اللي هي sensory ataxia. Okay. When we say this acute ataxia, we say this acute ataxia when the presentation is less than 7 days, within less than 7 days. And self-limiting syndrome, frequently post-infectious. Epidemiology, acute ataxia accounts 35% to 60% of all cases of pediatric ataxia. Usually, acute ataxia occur in children less than 6 years old, but may occur in older children and adolescents. Pathogenesis, it is autoimmune, okay? Occur after acute febrile illness like varicella infection, Coxsackie virus, ecovirus, enterovirus, malaria, typhoid, and some reported cases after COVID-19 infection and COVID vaccination. Okay, and vaccination of hepatitis B and varicella vaccination. طيب here we talk about acute cerebellar ataxia. Okay, to diagnose acute cerebellar ataxia, we diagnose by exclusion. Okay, after exclusion of other serious condition or illness. It is a rapid progression of symptoms develop over hours to 1 or 2 days. In cases associated with prodromal, after a prodromal illness, ataxia follows days to weeks. Right. Symptoms, first symptoms or the main symptoms came with gait disturbance. Primary symptom in most patients and limited to the fine motor control problem or tremor. And nystagmus can occur in 50% of cases, as like speech irritability, vomiting, or headache. طيب الكلينيكال examination. Any clinical examination for any patient came with you, firstly we do ABC as mentioned from our colleague. ABC in acute ataxia, we need to exclude the intracranial pressure. We need to exclude the bradycardial hypertension, irregular breathing, and if there is fever, it is guide us to certain diagnosis. Cerebellar signs, patient present with gait, wide base gait or unsteady gait, speech abnormality, fluctuation في الكلاريتي، في الريزم، في الفلوينسي، في التون، في الفوليوم. Difficult في البوستشر, impaired coordination and targeting of voluntary movement. Dysmetria and dysphokinesia. Hypotonia and tremor and gaze nystagmus. Investigation to exclude other causes in acute cerebellar ataxia. When patient came to ER, first we need to do toxicology screening. Okay, and if there is any specific drug ingestion in history, we should exclude and take toxicology screening. Lumbar puncture also to exclude the CNS infection, meningitis, encephalitis. CSF in acute cerebellar ataxia may be normal. Maybe there is lymphocytic polycytosis with elevated protein in 25 to 50% of cases, or maybe increased in immunoglobulin D in 50% of cases, or there is oligoclonal band in 10 to 17% of cases. Imaging, we need to do MRI brain, and MRI brain is superior for CT because it shows the posterior fossa. MRI it is not pathognomic, and maybe there is abnormal MRI with acute cerebellar ataxia. Maybe there is enhancement is bilateral cerebellum. It is not indicated in acute cerebellar ataxia, but indicated in certain or atypical feature on presentation. Once the patient is present with altered consciousness, or there is symmetrical focal weakness, sensorless or hyperreflexia. Okay, or there is atypical course, previous episode of ataxia, worsening ataxia, new unremitting headache, worse with lying flat or with valsalva, and improve with vomiting, possibility of head or neck trauma. This indicate for imaging. طيب differential diagnosis. Differential diagnosis of acute ataxia or other causes present with ataxia, toxic ingestion, as we mentioned. This is the second most common cause of acute ataxia in children. Okay, toxic like alcohol, antiepileptic like what? What antiepileptic present with acute ataxia? Example, share with me, please. Phenytoin, very good. Carbamazepine, very good. Benzodiazepine, Okay. And environmental toxin like mercury, lithium, and lead. Okay. Toxin affect the consciousness. Okay. Exclude the toxic ingestion. Exclude the infection like meningitis, encephalitis, and labyrinthitis. Post-infectious and autoimmune condition. Okay. Exclude الأوبسيكلونس مايكلونس syndrome. طيب الأوبسيكلونس multifocal myoclonus present with behavior irritability and 50% of patients with Abshanky myoclonus have neuroblastoma. Okay, and here we need more imaging, like abdominal imaging, to reach the diagnosis of neuroblastoma. Acute cerebellitis, following variety of infection, and there is reported cases after COVID-19. Patient at risk of malignant cerebellar edema and obstructive hydrocephalus require urgent measurement to lower increasing intracranial pressure and osmotic therapy, or temporary CSF diversion or decompressive craniotomy. Okay, this as complication. MRI, patient with acute cerebellitis, there is leptomeningeal enhancement and bihemispheric signal change or swelling. Treatment of patient present with acute cerebellitis, high dose glucocorticoid, and close monitoring for patient. Acute disseminated encephalomyelitis is a common presentation with ataxia present with multifocal neurological symptoms and encephalopathy. Autoimmune encephalitis, ADEM, acute disseminated encephalomyelitis. To reach the diagnosis, we do MRI. Okay, treatment with glucocorticoid, and there is characteristic feature in MRI treatment with glucocorticoid. Autoimmune encephalitis and lambda receptor encephalitis characterized with wide clinical spectrum of presentation, ataxia, abnormal movement, psychiatric behavior, and seizures. Okay. Also in autoimmune encephalitis, we give IVIG and glucocorticoid. Guillain-Barré syndrome. Patient with Guillain-Barré syndrome can present with acute ataxia, and there is subacute ascending weakness and absent reflex. And as we know, we do nerve conduction study to reach the diagnosis, and we give IVIG for treatment. Structural abnormality. Structural abnormality like traumatic brain injury, posterior fossa tumor, and stroke. Metabolic or neurodegenerative disease like hypoglycemia. Patient with hypoglycemia can present with ataxia. Multicerebral urine disease, heart nerve disease, biotinase deficiency, and mitochondrial disease. And as we mentioned, there is attack of ataxia. After exclusion of differential diagnosis, we can reach to the diagnosis of acute cerebellar ataxia. Diagnosis, as we mentioned, by exclusion. Just طيب. Management, as we mentioned, it is self-limiting condition. The management just is supportive and evaluate the patient after 2 to 3 weeks. The symptoms must disappear, and if the symptoms persist or worse, or there is new symptom develop, patient should be reevaluated for other cause of ataxia, as we mentioned in differential diagnosis. Prognosis, it is self-limiting condition, and it has good prognosis. Up to 10% have long-term neurological sequelae once the patient is old or have AB after AB virus infection. Thank you.
Thank you, Dr. Marwa, for your very nice presentation. And you highlighted a very important topic in pediatric neurology and general pediatrics, approach to child with acute ataxia. And I mean, the most important things to deal with emergency related to child with acute ataxia. That could be like encephalitis or meningoencephalitis or obstructive lesion or, ADEM, inflammatory demyelination disorder, or toxin, that is treatable issue. And then this is a very important issue. And then, your approach is very nice, and we are really all are enjoyed with what you said. And then we want to ask if there is any question. We are ready to respond. You have a good time, Dr. Marwa. You can enjoy with your time. If you could, any question? Dr. Marwa, in our situation in Sudan, say in our situation in Sudan, if the child acutely presented with acute ataxia, what we can do? I mean, we know our setting, what we can do in our home.
Okay, from the history, we can exclude other causes, as we mentioned. There is a clear history of toxin, history of drug. There is no fever. There is from the history. And whatever this or exclude, we have limited resource for investigation. Okay, from the history, we can exclude other causes. And from examination, once the patient came, exclude other causes, other signs of increasing trachea pressure and fever. And we can evaluate from the examination consciousness of the patient, if there is any neurological deficit, focal neurological deficit. Okay, after exclusion, we can with limited resource, we can do CSF, okay, to exclude meningitis, encephalitis, and we can admit the patient and observe.
Yeah.
Okay. Okay.
Okay. So in our home in Sudan,